Yes, there is some change in the scheduling of this session. So you are the first speaker, Dr. Arun.
Good morning. For the interest of time, I'm going to start because they already started my 15-minute clock. So I will start. It is a pleasure for me to be here again, and I would like to thank Hisham, Dr. Hisham Ghazali, and all of the organizers for organizing this beautiful meeting. I have two talks today. They are somehow related. The first one is related to a very specific subgroup of breast cancers, BRCA mutation related breast cancer, and its rather new treatment strategies. If I can move the slides forward. All right. So what I will try to cover within the next 15 minutes is the role of several therapeutic agents in the management of BRCA-related breast cancers, the platinums, of course, PARP inhibitors, mechanism of action, and also its use or studies in the metastatic setting, adjuvant, neoadjuvant, and also touch base on PARP inhibitor resistance that I think we are not discussing right now, but it's coming up very, very soon, and also other potential agents in BRCA mutation carriers. Just one very brief background. Over the years, I had given this lecture going into very much detail related to BRCA-associated breast cancers, but just to summarize, most of the BRCA, especially BRCA1-related breast cancers, are high grade. About 70% are ER negative, and again in BRCA1, 40 to 60% are actually triple negative. And also, when we look at the BRCA mutation rate in triple-negative breast cancers, is anywhere between 11 and 37% reported in the literature. And we actually had published our own prospective data where in triple-negative breast cancer patients diagnosed before age 40, BRCA rate was 23.5%. And if we tested all patients with triple-negative breast cancer before age 50, regardless family history, their BRCA rate was 17%. And in fact, as you know, in 2011, the guidelines changed to recommend to test all triple-negative breast cancer patients diagnosed before age 60, regardless family history. And since we have been increasingly doing so. Before I go into the platinums and the PARP inhibitors, I just want to show two slides showing that how do patients with BRCA mutations respond to conventional chemotherapeutic agents with anthracyclines and taxanes. And I will refer to our study that looked at, in the neoadjuvant setting, the use of anthracyclines and taxanes in BRCA mutation carriers, BRCA1 and 2, and also patients who were negative. And in this study, and again, I'm just trying to give the point here, we have shown that in BRCA1 mutation carriers, the PCR pathologic complete response was 46%, and in the BRCA tested but negative patients, 22.4%, which is very similar to our historical control. The reason I'm showing this is patients with conventional treatment, anthracyclines and taxanes in BRCA mutation carriers, are already responding pretty good to standard therapies. But the question is, can we further improve on the PCR rate or outcome if we add platinums and PARP inhibitors in these BRCA mutation carriers? So let's start with the platinums. This is the, and I'm summarizing here the prospective trials in mutation carriers. This is the prospective trial comparing platinums to taxane in metastatic triple-negative breast cancer patients, or also patients who have BRCA mutations. And again, just to show the important points of the study, in the overall population of triple-negative breast cancer patients, the response rate was the same for carbo versus docetaxel, about 31.4 and 35.6%. So that was not statistically different. However, when the data was analyzed by BRCA mutation status, you can see a huge difference. So individual women with breast cancer and a BRCA mutation had a much higher response rate to the platinums, 68% versus 33% for docetaxel. Whereas in patients with no germline mutations, the response rate was not different. This was a subgroup analysis, of course, but the difference is rather big. In terms of neoadjuvant studies in BRCA mutation carriers, most of the studies, and I will give a more broader summary within my next talk, is done in patients with triple-negative breast cancer. Amongst those neoadjuvant studies, some of the studies included also individuals with BRCA mutations, so it's kind of a subgroup analysis. There's this one study, Polish study, that looked only at BRCA mutation carriers, and the PCR was 83%, but this was a retrospective study, so this is a rather very high PCR rate and is not prospective. The other study I will mention right now is the JEPAR-6, though, that was actually done in all comers. It reported on the triple-negative breast cancer subset, but they also looked at the BRCA subset, so I want to go over that study. The JEPAR-6 study, as you know, is a study where patients were randomized to a taxane, an anthracycline, and bevacizumab plus minus carboplatinum. So basically looking at the addition of platinum in the neoadjuvant setting. Now when we look at the triple-negative breast cancer subgroup, the PCR rate when you added platinum was higher, 37% versus 53%, about a twofold increase PCR rate. But when they looked by BRCA mutation status, so this is the in these mutation cohort, there is no difference. So again, this is not a prospective study, and I keep pointing that out. This is a retrospective analysis, but it appears that whereas we showed that the platinums were more effective in the metastatic setting, in the neoadjuvant setting right now based on this study, the platinums might actually not be as effective in mutation carriers, but this is a retrospective study. And in fact, in the study, when they looked at the disease-free survival, what predicted improved disease-free survival was actually not the mutation status, but achieving a PCR. So as you can see from these two lines, whether the patients had a mutation or not, as long as they achieved a pathologic complete response rate, they had a better outcome. But again, all retrospective analyses. That's why it's very important that we are very excitingly awaiting the results of this prospective neoadjuvant trial that we are participating as well. It's a prospective trial where BRCA mutation carriers are randomized to 4 cycles of AC versus 4 cycles of cisplatin. Then they go to surgery. The primary endpoint is PCR, and then after surgery, it's the physician's choice whether the physician wants to give more platinums or taxanes, or if the patient is initially randomized to cisplatin after surgery, the physician can go back and give AC. So the PCR is the primary endpoint. It's an ongoing study. Hopefully it will finish accrual within this year, and we'll have the PCR data. But this is a prospective study that I think will enlighten us about the role of platinums in the neoadjuvant setting for BRCA mutation carriers. So how about PARP inhibitors? As you know, the mechanisms of DNA repair, there's DNA damage can be a result of environmental factors, UV, radiation, normal physiology, chemotherapy, radiation therapy, and the cell obviously has different pathways to repair it. For example, double-strand breaks are majorly repaired by BRCA1 and 2 proteins by homologous recombination, whereas single-strand breaks, DNA ducts and base damage, and replication lesions are repaired by PARP enzymes via base excision repair. So in a normal cell, you have these two pathways functioning well, the homologous recombination and the base excision repair. In BRCA mutation carriers, you have a defect in homologous recombination, but the PARP enzyme and the base excision repair works, so kind of the cell survives. However, if you have a BRCA mutation carrier and treat that patient with a PARP inhibitor, you are basically inhibiting all of the repair pathways, and that results in cell death. So that's kind of the baseline, very simplistic mechanism why PARP inhibitors work in BRCA mutation carriers more. I will not go through the details of these studies because of the interest of time, and these are not new studies, but the point is that in BRCA mutation carriers, first, second, or third line, the response rate, the objective response rate with PARP inhibitors ranges anywhere between 30 to as high as 60%. And the response is mostly seen in BRCA mutation carriers, not in BRCA normal or non-BRCA triple-negative breast cancer patients, so usually seen in BRCA mutation carriers. And these are the phase 2, phase 3 ongoing large prospective trials in BRCA mutation carriers in the metastatic setting. And I will today report on the two very recently reported outcomes with olaparib and talazoparib. These are the first agents where we have results from prospective trials. The first trial is the Olympia trial that randomized in the metastatic setting patients to olaparib, 300 milligram tablets BID, or chemotherapy that is physician choice, either capecitabine, eribulin, or vinorelbine. The primary endpoint is progression-free survival, and secondary endpoints overall survival and objective response rate. And this study was long awaited, so this was reported at ASCO. And here you see the results. The primary endpoint was progression-free survival, and indeed the survival was significantly 3 months longer for the olaparib arm versus chemotherapy choice. So it met its primary endpoint. Overall survival, though the data is not 100% mature, was not different. So olaparib versus chemo did not make a difference. When we look at the objective response rate, 30% versus 60% for olaparib, that was also statistically significant, but that was a secondary endpoint. So this is one study with olaparib. The second study that was, also the side effects, as expected, more neutropenia in the chemo arm and a little bit more anemia in the olaparib arm. Other than that, the side effects were not that different. The second prospective single-agent PARP inhibitor trial is the talazoparib study that was reported at San Antonio, again randomizing patients with metastatic breast cancer, only BRCA mutation carriers, to talazoparib or physician choice of therapy, capecitabine, eribulin, vinorelbine, and this study also had gemcitabine. And again, the primary endpoint was progression-free survival, and again, this study was met. Thank you. This study was met, the primary endpoint was met with a 3 months progression-free survival benefit. The secondary endpoint was overall survival, which was not met, but again, as the other study, the data is not yet mature. The other secondary endpoint was objective response rate, and very similar to the previous study, around 30% increased to 60% with the PARP inhibitor. So what we can say is in the metastatic setting that first, second line treatment for BRCA mutation carriers should now include PARP inhibitors. And in fact, the FDA just approved last week olaparib for metastatic breast cancer with germline mutations. The other area is interesting. In the adjuvant setting, there is no standard of care right now, but a study is ongoing with BRCA-associated breast cancer. Olaparib versus placebo is an ongoing study. And there are some smaller studies looking at PARP inhibitors, another one, rucaparib, in a phase 2 trial, if there is residual disease after neoadjuvant chemotherapy, but the preliminary results really didn't show any benefit at this time. And finally, we have done a pilot study in the neoadjuvant setting with talazoparib, just a feasibility study, and showing a decrease in volume measured by ultrasound. The PCR rate is currently being analyzed. And finally, mechanisms of resistance to PARP inhibitors will be emerging that can include restoration of BRCA function, loss of p53 expression, and other mechanisms. And studies now trying to overcome PARP inhibitor resistance is ongoing. And in fact, we are doing a BRCA octopus trial. We are about to start it in a couple of months. And lurbinectedin is another new agent that generates double-strand DNA breaks. And in a study in previously treated BRCA-positive patients, the response rate was 40.7%, significant. So in conclusion, for BRCA mutation carriers, PARP inhibitors are effective mostly only in BRCA-positive patients and not in the negatives. In the metastatic setting, it's a new standard of care right now, at least in the US now, as of last week. In the adjuvant setting, PARP inhibitors, a phase 3 trial is ongoing, and in the neoadjuvant setting, it looks promising. Platinums are effective in the metastatic setting. In the adjuvant and neoadjuvant, studies are ongoing. I cannot say it's standard of care yet. And then new agents such as lurbinectedin and others are being currently investigated. Thank you very much for your attention.
Thank you very much, Professor Banu, for this excellent presentation. And now I have the pleasure to introduce Professor Marwan Rost. And the presentation, the title of the presentation is Inflammatory Breast Cancer.